Oh, today we'll be talking about dizziness, vertigo, and imbalance after a brain injury. And specifically, these talks are geared towards brain injury survivors. So that's what this is how this talk is going to be directed. But I will try, I know that there are providers here as well, and I will speak to that. So for today's talk, I'll be talking about, I'll be focusing on concussion, which is considered a mild traumatic brain injury. Let me just hide this here. Considered a mild traumatic brain injury. And I won't be referring to moderate to severe TBI, as there are other considerations for them, since there's usually like a focal neurological change. So I'll be talking about the significance of dizziness after a brain injury. What is the vestibular system? And I will explain what is on my head. What are common symptoms associated with vestibular dysfunction? What's the difference between dizziness, vertigo, and imbalance, since a lot of that terminology is sometimes used interchangeably? And what are some common causes of vestibular dysfunction after a concussion? And what is vestibular rehabilitation? Oops. Okay. So dizziness is one of the most commonly reported symptoms after a concussion, and it's really only second to headaches. It's been shown that the presence of vestibular and visual issues soon after a concussion is associated with a higher risk of developing persistent symptoms and having a prolonged recovery. So for the majority of concussed patients, recovery usually occurs within the first two weeks, but there is a percentage of concussed patients who go on to develop persistent symptoms. And then this is often called post-concussion syndrome, or considered as having persistent post-concussive symptoms. So dizziness is a strong predictor for prolonged recovery because it tends to contribute to more anxiety, depression. It affects social functioning and impacts the ability to return to school or work. So this is why dizziness should be screened for early on in order to address it as soon as possible. And there is strong evidence that dizziness that is associated with vestibular dysfunction can be modified with vestibular rehab, which we'll look at later. So it's important to note that there are many other causes of dizziness that may be indirectly related to the vestibular system, and that includes psychological. So there are many overlapping circuits with anxiety and vestibular processing that can cause functional and psychiatric causes of vestibular symptoms. Autonomic. So the autonomic nervous system is associated with involuntary functions like blood pressure and heart rate, and it needs to be sensitive to large position changes and exertion, exercise, or increased effort. However, alterations in autonomic regulation after a concussion can cause abnormal blood pressure or heart rate responses, resulting in dizziness and lightheadedness with position changes and exertion. So usually there's a balance between the sympathetic and the parasympathetic nervous system. So it's more commonly known as like our fight or flight and rest and digest nervous systems. But after a concussion, the sympathetic nervous system can go into overdrive, and that's when issues can arise. Cervicogenic, which means coming from the cervical spine. So basically, because of the close proximity of the vestibular system and the cervical spine, a cervical spine injury, like a whiplash injury, which commonly comes along with a concussion, can result in faulty proprioceptive input to the vestibular system, resulting in a sensory mismatch. And then this can cause dizziness. And this list is not exhaustive. There are definitely many other causes of post-traumatic dizziness. So this is a little graph I tried to make to show where the vestibular system is in the grand scheme of things. I don't love it totally, but basically what I'm trying to say is that the autonomic nervous system is central because that's where it regulates like many of our physiological processes. And then the proprioceptive, which are our muscles and joints, visual and vestibular systems, they're constantly in communication. And then on top of that, there's our psychological components, like our mood and emotions can have an effect. Our general health, nutrition, and sleep can have an effect. And then in terms of the cognition, I put asterisks there because I think of it more so as an overarching circle around everything, because really, if you are thinking so much about staying balanced and upright and just, being able to get around in your day to day, you're not going to have extra resources to remember things and pay attention and be able to focus on having a conversation with someone, since you're just so focused on staying balanced. So that's why I have asterisks around the cognitive circle. Okay, so the vestibular system is associated with what we know as the inner ear. It's located deep in the ear, and it's encased in the bony labyrinth, which is a cavity within the temporal bone, so the bone on the side of our heads. You can see that the peripheral vestibular system consists of the semicircular canals, the cochlea, and then the vestibular cochlear nerve. And the central vestibular system consists of the brainstem, cerebellum, and the cerebral cortex. They're not shown in this picture, but basically the pathways to and from the brainstem are crucial because they receive and relay information from all the sensory systems. The cerebellum helps to fine-tune movement and adapt them based on the task and the environment. And then the cerebral cortex is involved in the integration and processing of sensory and motor information for overall spatial awareness and orientation. And then in terms of the vestibular cochlear nerve, it's still considered the peripheral system, meaning so central means the brain and spinal cord, and then peripheral are the structures outside of that. So it's still considered the peripheral nervous system until it enters the brainstem, and it has two portions. It has the vestibular nerve associated with balance and the cochlear nerve associated with hearing. And since you have two vestibular nerves, one from each ear, they must work together when sending signals to the brain. So the inner ear, which is also called the labyrinth, consists of two major components. So the cochlea, which is the organ for hearing, and then the vestibular organ, and there's one in each ear. It consists of three semicircular canals, which are the ones that are on my head. And they're responsible for detecting angular rotational acceleration of the head. And they can detect this in three planes. So there's a superior, posterior, and then horizontal. And these canals are oriented roughly 90 degrees to each other. Okay, let me just check the chat, just in case there's anything. Baker, I'm not sure if I can do that right now. Sorry. I hope you can still see the presentation though. I think it's just because since I've started it, I don't know if I can change it. Maybe if I can change the size of me. Sorry about that. Okay, so yes, okay. So then, yes, so the canals are oriented roughly 90 degrees to each other. And then there are two otolith organs which detect linear movement and the force exerted on the body by gravity. And it's not shown in this picture, it'll be in the next slide. So because we have a vestibular organ in each ear, when there is an injury, the other side can compensate for the reduced function of the injured side by recalibrating the signals to the brain. And this is basically the premise of vestibular rehab. Okay, so in terms of the major functions, okay. So in terms of the major functions of the vestibular system, so there's four major functions. So there's gaze stability, which involves the ability to keep a clear image while moving your head. And issues with gaze stability results in oscillopsia. Oh, I can never say that properly, oscillopsia, which is a sensation that the surrounding environment is moving and unstable when it is in fact stationary. So often my patients will describe their vision as bouncing and being wobbly. Postural stability and balance is another function, and that can include stability when sitting, standing, when being still, or moving. Spatial orientation refers to the ability to kind of determine and adjust body orientation in relation to the surrounding environment and to be able to navigate properly through space. So for example, it's the ability to sense what is vertical and upright, and then being able to adapt to that. So like if you were to walk on a slope on the ground, like on a ramp, and to know what is straight and adjust to that. So issues with postural stability and spatial orientation can result in the abnormal sense of movement and orientation. So for example, a patient may describe that it feels like the floor is tilted to one side, or they feel like they drift to one side when they're walking. And in terms of cerebral perfusion, so basically the vestibular system has many connections with the autonomic nervous system through the brainstem. And so when the vestibular system senses large postural changes, like when you stand up from a lying position, it has to quickly communicate with the autonomic nervous system to adjust blood pressure and heart rate in order to ensure that there's sufficient blood flow to the brain with position change. And so issues with this result in orthostatic intolerance, meaning that when you make a position change, like sitting up from a lying position, you may feel lightheaded and you might need a moment before standing up. So basically, for vestibular function, it includes both sensory and motor systems, and it's involved in many different roles related to postural control and balance, including, so we know, stabilization of the eyes and head, controlling center of mass, using certain muscle contractile patterns, sensing and perceiving motion using all of the sensory systems, and then maintaining verticality when interacting with the environment. So this chart basically shows that there are many overlaps and redundancies among the various sensory modalities, which is helpful to ensure that we maintain our balance after a dysfunction to one or more of the sensory systems, like the vestibular system. So I'm going to focus on this one, one of the major functions of the vestibular system, which is gaze stability, and it is related to the vestibulo-ocular reflex. So we're going to focus on this. So the VOR, as it's more commonly known, coordinates eye and head movement in order to allow for stable vision during head movement. So it involves a 3-neuron arc that produces compensatory eye movements in response to head movement. So because of that, the VOR is one of the fastest reflexes in the human body, so that we always have clear vision. So for example, when your head moves in one direction, your eyes move in an equal amount in the opposite direction and at basically the same speed so that the target stays in focus. And this happens all the time. So even when we're walking, our head is not perfectly still. It naturally moves from side to side, up and down as you walk. Yet you probably haven't noticed that objects sway or jump up and down when you walk around. But when the VOR is not working properly, that's when patients experience oscillopsia, and that's when objects appear to jump or blur when you're in motion. And this reflex works best at frequencies greater than 1 hertz. So that's the equivalent of turning your head to the one side and the other side in 1 second. If your head moves slower than 1 hertz, then another system, the visual system, will take over the responsibilities of maintaining focus. And just so you have an idea of what speed our head moves for different activities. So for routine daily activities, it's between 1 to 4 hertz. Walking is about 2 to 4 hertz. Running challenges the vestibular system up to 10 hertz, depending on the speed and terrain you're running on. So if you think about all the physical activities that you want to get back to doing, like dancing or playing tennis, You can imagine the wide range of speeds that you need and how you need to move your head at higher speeds to be able to do those activities comfortably. And I do use a metronome a lot for vestibular rehab. And so you have an idea of what 1 Hertz is. I don't know if you can hear that. So that would be like, yeah, so that just gives you an idea. Okay. So given the trauma to the head and the location of the vestibular organs, a concussion can definitely result in vestibular issues. So yes, it can be due to a direct impact, but many times it doesn't require direct contact to the head. It can be due to rapid acceleration, deceleration forces, or stretch shearing of neurons that can cause trauma. So there can be injury to the peripheral part of the vestibular system, which is the vestibular organs and nerve, or the central part, which is the parts of the brain that process vestibular signals. And because the cause of vestibular impairment generally informs our direction of treatment intervention and prognosis, it's important to establish the cause of vestibular dysfunction for clinical management. Okay, so now dizziness is a non-specific term and it can describe a lot of different types of sensations. But what's most important to remember is that you need to be able to distinguish between dizziness, vertigo, lightheadedness, and imbalance. But definitely between dizziness and vertigo. So dizziness is kind of like a general sensation of floating or rocking, and there's many other terms I've heard. Whereas vertigo is a sensation of movement. So it could be either the person or the environment that's moving when there is in fact no movement occurring. So that's the main difference. Lightheadedness is also a common symptom reported, and that refers to the sensation of feeling faint or like passing out. And I often find that this is a term that's used often in older adults. So symptoms of dizziness or vertigo can occur when you're not moving or when you are moving. It could be in certain positions or with movement. And when there's asymmetrical activity in the vestibular system because of an injury, it can affect one's postural stability by making you feel like you're being pulled to one side or weighted to one side. So because dizziness is such a broad term, I often ask my patients to describe their symptoms using any word except for dizziness. So it makes them think about it a little bit more so that they can specify their sensation. And then on top of that, I ask for other qualifiers like the temporal course of their dizziness. So does it come on and off? Is it there constantly? Does it last for seconds to minutes to hours to weeks? Is it a new symptom, a long-lasting symptom, things like that. So basically there's a strong link, we know, between the visual and vestibular systems. So it's no wonder that visual disturbances can result after vestibular dysfunction. And many times if patients' primary symptoms are vision related, they'll often go to their optometrist first to assess for their vision symptoms. But an eye examination won't identify a pathology because the symptoms are of vestibular origin. So the patient doesn't have actual issues with visual acuity, which is what that exam assesses. It's acuity during head movement, which isn't provoked during those types of tests. And so these are all the types of visual disturbances that can occur after a vestibular dysfunction. If our balance system is working properly, we should be able to see clearly while we move, identify our orientation with respect to gravity, determine the direction and speed of our movement, and then make adjustments depending on the activity and the environment that we're in. And in order to do all that, we need a well-coordinated sensory motor control system that consists of accurate input from our visual, vestibular, and proprioceptive systems. So when there is conflict of sensory input coming from those areas, that's when we can experience imbalance and symptoms that are associated with it, such as all of the ones listed here. Now, because of the close proximity of the hearing structures to the vestibular system, damage to the auditory system can definitely occur following concussion. And damage can occur to the vestibular cochlear nerve or the cochlea itself, resulting in hyperactivity in the central auditory system. So symptoms associated with hearing can include hearing loss, distorted or fluctuating hearing, tinnitus, which can be described as these other types of sensations as well. And compared with tinnitus from other causes, tinnitus due to head or neck trauma can be a little bit more louder and more severe. And it's usually accompanied by a headache and associated with poor concentration and memory. And there's even something called somatosensory tinnitus, which is tinnitus associated with the head, neck, and sometimes even the jaw. And that doesn't occur with hearing loss, but I do find that it can be modified through manual therapy and treatment to the head, neck, and jaw. And then, so sensitivity to loud noises or environments. So there's different types of sensitivity. There's cochlear hearing sensitivity, and then there's vestibular hearing sensitivity. So with cochlear hearing sensitivity, usually patients feel ear pain, discomfort, and irritation when they hear certain sounds. And then with vestibular hearing sensitivity, when they're exposed to certain sounds, they can feel off balance. And then following a concussion, damage can definitely occur to the bones, the tiny little bones in the middle ear. And so that can also cause these types of symptoms. All right. Everyone is good. Okay. So when your brain is expending all of its energy, keeping you balanced and stable, and that's something that's normally done automatically, there isn't a lot left over for you to use for cognitive processes. So because of that, many concussed patients with vestibular dysfunction, they struggle with concentration, attention, and memory. Many may feel confused, disoriented, have difficulties comprehending and remembering directions and instructions. They often need repetition and written reminders. Some patients may feel embarrassed about being in public. They may stop spending time with their family and friends because they have difficulties understanding conversations, especially when there's a lot of background noise and distractions. And activities that used to be automatic, that they never even had to even think twice about, now it requires more thought and more focus. So because of that, you experience more mental and physical fatigue that's not proportionate to the level of activity. So you'll often say that you feel drained of energy and require more rests and naps throughout the day, even though you may feel like you've done nothing. And so in these situations, you often have to pace and plan your day in advance so that you don't wipe yourself out by the end of the day, which also sometimes means that you can't be spontaneous. So there are many ways that you can overcome these types of cognitive difficulties, and it can include neuropsychological treatment that involves cognitive rehab, but it usually just involves increasing your awareness and self-monitoring of your difficulties, and then learning strategies to deal with those areas that you identified. I will definitely, I see the question here. I'll definitely have this presentation forwarded to everyone who has come today. And this presentation is being recorded and will be on our YouTube channel. And I'm really sorry for talking quickly. I'll try to slow down, but I also want to try to get through everything before the end of the hour. Okay. Yes, Joanne, I definitely understand. Okay, so Yes, I'm sure you've heard of the mind-body connection. So it's no surprise that a physical impairment can have an effect on emotional health and vice versa. Emotional and psychological factors can definitely have an impact on one's capacity to recover from injury, like a concussion. So while it's important for concussed patients to understand their physical symptoms, it's as equally important for them to understand their psychological symptoms because they can often trigger or exacerbate their physical symptoms. Emotions can trigger physiological events that causes a vicious cycle where physical symptoms that were initially triggered by the vestibular dysfunction result in anxiety or some sort of emotional response, which further increases the feelings of dizziness and vertigo and other symptoms. And also, if you experience a sudden onset of vestibular symptoms, like a sudden episode of vertigo, that unpredictability and variability where you just don't know when it could happen again, that can be terrifying and unsettling and cause psychological symptoms. So a major aspect of concussion injury is that it is an invisible injury, which can make many patients feel alone and misunderstood. Concussed patients, they often just don't look sick or unwell. So unlike a broken arm where you can see the injury and sympathy can be generously given, a concussion isn't visibly seen. So a concussed patient may not want to constantly describe their symptoms and issues with the people around them, which can lead to them wanting to stay home. And then this can lead to social isolation and depression. So nausea and vomiting are common symptoms that are associated with vestibular dysfunction, especially when you have that acute episode of vertigo. There are many strategies to deal with these types of symptoms, and a lot of it involves medication. But these medications that are sometimes considered vestibular suppressants to calm down their overactive vestibular system, they're only meant for short-term use because long-term use of these medications can actually impede the process of vestibular recovery. And many times that's not known or made aware. And so I have a lot of patients who take them for many months or years. Motion sickness is associated with motion, like when you're riding in a car. So I often find that those patients who had motion sickness before their concussion, they are more likely to experience a worsening of their motion sickness after a concussion. And then the sensation of fullness and pain in the ears, and it can fluctuate and depend on the acuteness of the injury. Headaches can stem from a wide range of causes. And slurred speech can sometimes result usually from a central cause of vestibular dysfunction. So I just made a little chart here so that you can have a nice summary of the differences between dizziness, vertigo, and imbalance. And as a patient, it's good to be aware so that you can kind of give that information to your therapist so that they can have a better understanding of your symptoms and what direction to take. And then as a therapist, it's important to kind of make that distinction so that can also help your assessment and treatment direction. So the following are common peripheral and central vestibular causes of dizziness after concussions. I won't go through all of them. I will explore just some of them here. These are the ones that I most commonly encounter. So benign paroxysmal positional vertigo, more commonly known as BPPV, is a peripheral vestibular condition that occurs in the semicircular canals, these guys right here. It occurs when otoconia, commonly known as crystals, dislodge from the utricle where they normally are, and they're sitting on that membrane. They enter the canal where they shouldn't be. And since the canals are not meant to sense gravity, when otoconia enter the canal, it sends misinformation about gravity and rotation, and that causes vertigo. The majority of the cases of BPPV occur in the posterior semicircular canal, so the guys back here. And there are two types of BPPV. There's canalithiasis, where the otoconia dislodge and they float freely in the canal. And then there's cupulolithiasis, which is where the otoconia, they get stuck to the walls of the canal. Okay. So usually, usually the initial episode of vertigo occurs suddenly. So I hear that it happens when they turn in bed or when they wake up first thing in the morning. The vertigo lasts for a very short period of time, but it can come on again with certain positions and movements, especially head movements, like looking up or turning in bed. And when you're not experiencing vertigo, there could sometimes be a general sensation of imbalance, and you might just feel off. So with testing, a positive Dix-Hallpike or roll test, which are physical maneuvers that try to move the crystals within the canal, that will indicate whether BPPV is present. And this test is reliant on the observation of eye movements. So depending on the eye movements that are observed, it'll let the therapist know which variant of BPPV they have. And then the gold standard treatment is Canalith Repositioning maneuvers, and there are many types. So making sure diagnosis is accurate is important. And it's possible that one maneuver isn't going to completely fix it. You might have to perform it multiple times. You might have to do it over several sessions. And unfortunately, reoccurrences are quite common, especially within the first year. And once the vertigo resolves, if there are still secondary issues like balance, then vestibular rehab is helpful. So don't worry, you don't have to memorize this, but it shows you how many variants of BPPV there are, and so how important it is to be able to accurately observe for those eye movements so that the correct maneuver is performed. So this fancy headband I have here from Vestibular First, that's the company. It kind of helps me to provide education to my patients about what's going on during BPPV. And so because they replicate the fluid dynamics within the canals, it shows how the otoconia fall through the canal. So I'll show you here in a video how it does that. So I'm doing the test for the left Dix-Hallpike, and you can see once you're in that gravity dependent position, the otoconia are flowing through the canal at that rate because of the fluid composition. Okay, so vestibular hypofunction. So the affected structures include the peripheral structures. So that's the semicircular canals, specifically the horizontal, and then the pathways associated with the vestibular ocular reflex, which we saw was associated with maintaining stable vision during head and body movement. And it can occur on one or both sides. If the speed of the head movement doesn't match the eye movement, then vision blurs, and then that can result in dizziness, imbalance, and general disorientation. There are some clinical tests to assess the integrity of the VOR, such as the head thrust test and the DVA test. And then to address gaze stability, gaze stabilization exercises are key. So it's about prescribing exercises so that the specific head movements and speed that are impacted by the patient's daily activities are addressed. But we do know that they should be above 1 Hertz, since many of our daily activities are at that rate. Oculomotor issues. So because of the intimate connections between the visual and vestibular systems, oculomotor issues can occur after vestibular dysfunction, and they're associated with pathways in the central nervous system. So the brain, the brainstem, and the cerebellum. And so oculomotor functions can include gaze fixation, which is the ability to hold the eye stationary, saccades, which are rapid eye movements that move from one target to another, and smooth pursuits, which is the ability to focus on a moving target. There are many symptoms associated with oculomotor issues, but they're primarily related to the ability to see clearly, and then the ability to use that visual information to integrate it with the other sensory systems. And so oculomotor testing can show deficits in smooth pursuits, saccades, and then impaired visual motor functions. So treatment involves incorporating visual functions such as smooth pursuits and saccades into the vestibular rehab program, and you can collaborate with a neurooptometrist in that regard. So they're usually an eye care professional who specializes in the diagnosis and treatment of neurological conditions relating to the visual system. And there's a lot more research coming out now showing the value of oculomotor and vision rehab following a concussion. So it's just about finding the right practitioner who is well-versed in the area. So the reason why secondary anxiety and depression is included as a central cause of dizziness is because there are many common central pathways in the brainstem that perceive dizziness and vertigo and anxiety. There's a very strong relationship between emotional distress and vestibular dysfunction. So you can imagine how frightening an acute attack of vertigo would be and how it could trigger a vicious cycle of bringing on and then reinforcing symptoms. Patients can experience a wide range of unpleasant physical and emotional symptoms, with the nature of the stress response likely to vary depending on the underlying dysfunction. So it could be an acute episode of vertigo that gradually subsides, that will have a different stress response than unpredictable episodes of vertigo where you just don't know when they're going to come on. So naturally, because of that, patients will want to avoid experiencing these symptoms by using avoidance and safety-seeking behaviors. Not all patients will perceive or handle their vestibular stress in the same way. And so their ability to cope can determine long-term outcomes for their vestibular dysfunction. So this can lead to an inability to compensate properly for their vestibular dysfunction, and compensation is the basis of recovery. So normally a mild stress response within the context of a learning situation helps us to focus attention and improve learning and memory to facilitate compensation. But if the vestibular stress response competes with an additional stressor like anxiety, then this can prevent compensation. So just like physical rehab is important, we also need to be aware of emotional well-being, because that's conducive to their physical recovery. And then there are many different treatment strategies to help with that. So I won't go through all the components of a vestibular assessment, but here's a chart outlining those tests that are commonly used and what their results represent. So with these series of tests, it provides the therapist with an overall picture of the patient's vestibular function. But with many of these tests, you can't actually diagnose a vestibular deficit. So only these tests here can be diagnostic, whereas these ones are suggestive of a vestibular dysfunction, and that vestibular rehab could be beneficial. And then gait assessments are functional assessments. So they just determine how the patient's ability to walk affects their daily activities. So nystagmus, I'm just going to describe it quickly. So this is used as a major observation during vestibular assessment, and it's involuntary rhythmic eye movements. And I have examples here. So on the video on the left, this is in room light. And then you can see how during testing, her eyes moved in those directions. And then that, to me, indicated a specific type of diagnosis. The patient on the right had a chronic vestibular dysfunction, and in room light, I didn't actually see nystagmus, but then when I placed infrared video goggles, where she wasn't able to fixate in room light, then this is what was observed. So those eye movements are very crucial for our examination. And so a little bit more about the infrared video goggles. So basically, in the video goggles, so with the infrared video goggles, the patients are in the dark, so they're not able to use their environment and the room light to be able to fixate their gaze. And this is important because when a vestibular dysfunction is acute, a patient hasn't been able to develop compensations such as that to fixate their gaze. But then when a vestibular dysfunction is chronic, then they can start using their vision to fixate, and then that minimizes their nystagmus and then their sensations of vertigo and disequilibrium. So by using these infrared video goggles, we can bring out those underlying dysfunctions. So with these infrared video goggles, anyone can purchase them and use them, but it is quite challenging to observe for these eye movements. It does require skills and training and to be able to interpret them to determine what they signify. So just because of time, I'm going to kind of skim through this. So BPPV is a very common test for vertigo. And so these are the tests that are used, these positional tests to use to diagnose. Excuse me. And nystagmus is the eye movement that the practitioner is looking for. And based on the eye movement, the direction, the latency, so the delay in time of onset, and then how long the nystagmus lasts for, they'll be able to diagnose the type of BPPV and perform the correct maneuver. So do you remember what this chart represents? If I test you now, but don't worry about it. So it's just to show again that there are many variants. So here I am performing the left Dix Hall pipe test, which tests the left posterior canal. And then I'm observing for nystagmus, so the movements in their eyes. And again, I'll go through this quickly. So these are vestibular function tests that are typically performed by ENTs or even audiologists, at least in Canada. And so the goals of these tests are to determine the site and extent of a vestibular lesion, determine whether the lesion is peripheral versus central. And basically the implications of this is that it helps guide my treatment and helps with expectations of the treatment direction. So the goals of vestibular rehab are to restore normal gaze stability and postural control under static and dynamic conditions by reprogramming eye movements and postural responses to movement. So when it comes to treatment considerations, it's important that the exercises are most beneficial when symptoms are provoked by specific movements, positions, and environmental situations, because exercises are based on those specific triggers. Treatment is symptom or performance driven rather than determined by diagnosis. So I know I said earlier that it's good to know the cause of vestibular dysfunction because it does help guide clinical management, but ultimately treatment is symptom or performance driven. And the principle of decompensation is very important to consider because even though at some point you may achieve compensation and your symptoms may go away, they can come back months or years later. So it just means that the brain kind of forgot what it learned. So it's just a matter of returning to your vestibular rehab program again. And usually the recovery from decompensation is a lot quicker. But it's good to be aware of decompensation and potential triggers so that when it does happen, you're not surprised and you can just perform your exercises again. And also, if it's a trigger that is modifiable, such as having poor sleep or more stress, then you can make certain changes in your lifestyle to reduce the risk of decompensation. So these are treatment approaches that are commonly used in vestibular rehab. So gaze stability exercises is for eye-head coordination. It's very important that you do the exercises to specific speeds and contexts that are appropriate to the patient's daily activities, and that it's important to remember that they will provoke symptoms. It's just a matter of provoking a low level of symptoms that creates change in the brain and not be overwhelming. And here are examples of me performing exercises, either sitting, holding the target, or standing with the target on the wall. Balance and gait exercises are also very important, and it's important to do them in different types of tasks and environments, still and dynamic. Although when it comes to static balance exercise, it's kind of ironic because you're not actually standing still during these exercises. There are subtle postural corrections and sways that occur during static balance. And then dual tasking is very important because often after concussion, there's greater difficulties with intentional abilities that can affect daily activities. So it's important to incorporate multitasking with balance to assist with those types of daily activities. So here are examples of doing balance exercises on a variety of surfaces, doing it in narrow gait walking, and dual tasking where you're throwing a ball while walking. Visual exercises are to improve oculomotor control, and you can focus on gaze fixation, smooth pursuit, saccades, and convergence. So it's really important to remember that oculomotor control needs to be addressed in order to improve vestibular function, because the vestibular system is dependent on proper visual input and processing. And then, of course, visual and vestibular exercises are not useful or practical until you integrate them, because that's what our daily activities are all about. So as soon as the patient is able, as soon as you're able to tolerate them, you should integrate the two together. And then ultimately you want to prescribe graded, purposeful movement that stimulates real life experiences. So because visual dependence can occur after a vestibular dysfunction, our brains, starts to overutilize and rely excessively on visual information that can lead to symptoms with, complex visual environments. So surface orientation exercises are a form of sensory reweighing training. So we're training the brain to increase the use of proprioceptive cues instead of relying on their vision. And so you can perform these exercises in a variety of positions just to help your brain use the information from your body, your muscles, and your joints more than your vision. So here, you can do it lying down, sitting, or standing. And then, of course, the Canalith Repositioning maneuvers for BPPV. So this is a sped up version, but basically this, you go through a series of positions to relocate the crystals from the canal back into the utricle. And there are many maneuvers that exist, like I mentioned before. So it's important that you know that your therapist is aware of that, so that in case one maneuver doesn't work, you need to be reassessed and another maneuver may be more appropriate. And maintaining physical condition is obviously very important for many reasons, like maintaining fitness levels, brain plasticity, which is important for healing and compensation, improving sleep, mood, overall strength. But it's important to remember to consider the mode of exercise. So, walking outside is great because we stimulate the vestibular system. As we walk through space, our visual vestibular system has to kind of compare information and determine, your movement through space. But sometimes you might prefer the safety of walking on a treadmill, because you could hold on to the handlebars and you don't have to worry about bumping into people. But then at the same time, walking on a treadmill, you might experience that head bobbing motion that can cause dizziness. So then that's when a bike might be more appropriate. But ultimately, the goal is to remain below symptom threshold and then to gradually increase your time, speed, and distance as tolerated. And so stress management is important because, like we said before, there is that vicious cycle between stress, anxiety, and your physical symptoms that can feed on itself. And then this can impact vestibular recovery. So these are different techniques that can be used. I've used a variety of websites, videos, audio clips, apps, but for more guidance, a referral to the appropriate provider may be needed. And then, of course, there's a lot of evidence that's coming out regarding the efficacy of vestibular rehab specific to concussion. We know that it is effective for non-concussed individuals that have dizziness. But when it comes to concussion, it's really important that if there are vestibular issues, that they are provided targeted interventions. And not only that, but the interventions have to be individualized to the patient's level of functioning and expectation of recovery. And so because of that, it's important to have a full team care approach so that their dysfunctions are addressed from all possible angles. All right, I made it to the end.